In summary, these are the advantages of oral liquid-based cytology. 1. Much simpler techniques for general dentists. 2. Fewer inadequate specimens. And 3. A higher standard of specimens. For early detection of oral cancer, the role of general dentists is very important. Oral cancer screening devices for general dentists need to be simple technique. Oral LBC don't need complex technique, and every general dentist can perform this examination without a hard training. And for cytopathologists, standardized fine specimens are needed for a correct diagnosis. Therefore, I think that oral LBC is a useful examination for early detection of oral cancer. Concerning the cytologic grading system of oral accelerated cytology, in 2015, Japanese Society of Clinical Cytology (JSCC) established the first cytologic grading system in Japan. The Japanese grading system has 5 categories: NIRM, low SIL, high SIL, SEC, and INF. In our general dental clinic, we performed oral LBC for oral cancer screening since 2013. Among 99 examined cases, 2 cases were diagnosed cytologically as SCC class 5 and also diagnosed histologically as SCC. And 1 case was cytologically diagnosed as erosive class 3 in a clinic, and then he was diagnosed histologically as SCC in the consulted Tohoku University Hospital. This is the first case performed oral liquid-based cytology in a clinic. Case 1, 80 years old male. This case was obviously diagnosed clinically tongue cancer. 50 by 45 mm size ulcerative lesion with bleeding and induration were found on the right side of his tongue. Oral liquid-based cytology showed that basal, parabasal, and intermediate atypical cells. These cells showed high NC ratio and nuclear hyperchromasia. A few superficial atypical cells shows abnormally configured keratotic cells with orange color cytoplasm. In high-power fields, a light green colored atypical deep layer cell showed irregular nuclear membrane and dense cytoplasms, so this case was diagnosed as squamous cell carcinoma SCC class 5. And as consulted Tohoku University Hospital, this case was diagnosed histologically as squamous cell carcinoma well differentiated. Next case, we could diagnose cytologically as early stage cancer, stage 1. 70 years old male. The clinical diagnosis was soft palate ulcer, non-specific. 10 by 8 mm size small ulcerative lesion with slight bleeding were found. Induration was unclear. The clinical diagnosis was soft palate non-specific ulcer. However, an oral LBC, basal, parabasal, and intermediate atypical cells showed high NC ratio and nuclear hyperchromasia. Thin light-green colored atypical deep layer cell showed irregular nuclear membrane and dense cytoplasm. So this case was diagnosed as squamous cell carcinoma SCC class 5. This patient was referred to the Tohoku University Hospital, was diagnosed as squamous cell carcinoma also histologically. Next case was cytologically diagnosed as low-cell class 3 in a clinic, and were diagnosed histologically as SCC in the consulted Tokyo University Hospital. Case 3, 70 years old male. Clinical diagnosis was tongue cancer, 20 by 15 millimeter size ulcerative lesion with bleeding and induration was found. In oral LBC, superficial or intermediate cell shows nuclear hyperchromasia. The cell shows abnormally configured keratosis with orange color cytoplasm. Few single orange colored atypical cells show irregular nuclear membrane and dense cytoplasm. This case was diagnosed as low-cell class 3. This patient was referred to the Tokyo University Hospital and performed the histological examination, and he was diagnosed as squamous cell carcinoma. We could diagnose this patient as early stage, stage 2. In a clinic, we usually refer to cancer specialists and patients diagnosed as low cell, high cell, and SCC cytologically. Next case was suspected gingival cancer clinically, but he was cytologically diagnosed as NIRM. Case 4, 70 years old male. Clinical diagnosis was gingival cancer, 80 by 15 millimeter size, deep ulcerative lesion with induration was found on gingiva under his full denture. In oral LBC, many superficial keratinoid mature epithelial cells show low NC ratio and nuclear neutrophil predominant inflammatory cell could be seen in the necrotic background. Orange-colored keratinoid superficial cell is and the light green-colored intermediate cell show low NC ratio. So this case was diagnosed as NIRM class 2. In this case, after full denture conditioning treatment, his lesion got better soon. Finally, I will comment concerning pitfall and limitation of oral liquid-based cytology. The cytological diagnosis of oral squamous cell carcinoma greatly depends on the sampling depth. Therefore, it is difficult to diagnose early invasive squamous cell carcinoma with thick keratotic surface layer. For example, such white lesion with thick keratotic lesion, oral LBC is not suitable. So we should perform incisional biopsy. This is the summary. I believe oral liquid-based cytology is the most useful devices for the screening of oral cancer, especially ulcerative or erosive mucosal region. If oral liquid-based cytology become more common for general dentists, we can save a lot of lives of oral cancer patients. Thank you.